like to now welcome to the stage, all the way from Singapore, Dr. Su Ping Thang to be speaking on FDG PET-CT complementary role to PSMA PET-CT. Thank you very much.
Okay, thank you for the introduction and a very good morning to all. Thanks, Michael, for the invitation for this meeting. So I'm going to talk about FDG PET and how it complements PSMA PET. Oops, sorry. Okay, so we have heard this morning how PSMA PET is very good in detecting prostate cancer. So what really is the added value of FDG PET, and in which clinical setting will it benefit patients? So we're comparing very different mechanisms here, so FDG PET versus PSMA PET. So FDG stands for fluorodeoxyglucose, is a sugar analog, and is looking at glucose utilization compared to PSMA PET on PSMA expression. So just going back a little bit on basics, so glucose utilization in normal tissue can be quite different from tumor. So most tumor cells do not undergo the usual oxidative phosphorylation as observed in normal tissue cells, but through a less efficient pathway of aerobic glycolysis. As you can see, the number of ATP here is less in aerobic glycolysis, so less energy produced. So in most tumor cells, there's a higher trapping of glucose, therefore FDG, to produce equivalent energy. However, in early prostate cancer, which is more metabolically efficient, there's a transition back from aerobic glycolysis to oxidative phosphorylation. So in early prostate cancer cells, there's a less trapping of glucose and therefore FDG compared to the later stages of prostate cancer and other malignancies. So I think Michael and team have very nicely summarized the role of FDG PET in prostate cancer. So as discussed previously, early prostate cancer tends to have a lower FDG accumulation, and therefore PSMA PET is superior to FDG PET in this clinical setting. However, FDG PET do have a role in aggressive disease, especially if the grade group scores is 4 or more. In non-PSMA active disease, often associated with aggressiveness of disease, and when there's a concern for neuroendocrine differentiation, when the trapping of glucose is also high. So when we look at this study where they use FDG PET in the earlier stages of prostate cancer in 148 of their patients with Gleason score 8 to 10, which is equivalent to grade group scores 4 or more prior to prostatectomy, they found that patients with a higher intraprostatic FDG uptake have higher Gleason score, had a higher risk of local invasion and lymph node metastasis, a twofold increased risk of biochemical recurrence in the year following prostatectomy, and a shorter time to castration resistance following prostatectomy, so suggesting that preoperative FDG PET can identify aggressive disease. So another study evaluating the combination of FDG and PSMA PET, again prior to prostatectomy in 42 of their patients, found that PSMA PET is still superior to FDG PET in detecting primary prostate cancer, but tumors with FDG uptake are often larger size, of ductal dominant type compared to the more common actinol dominant type tumors, and more likely to undergo metastasis as staging and biochemical failure post-operatively. So for earlier stages of prostate cancer, in general, PSMA PET is better than FDG PET, but FDG PET do have a role in identifying aggressive disease, but the use of dual PET imaging, PSMA and FDG, is often adopted in the advanced metastatic disease setting, where it can be used as an additional tool to PSMA PET for better selection of patients for radioligand therapy. So when we look at the two landmark trials for PSMA radioligand therapy, the VISION as well as the therapy trial. The VISION trial is the trial that compared lutetium PSMA to best supportive care, and therapy trial, lutetium PSMA therapy to cabazitaxel. They use a slightly different baseline PET criteria. So both uses PSMA PET with slightly different tumoral threshold, but therapy trial also uses FDG PET as a baseline PET selection. As you can see, the screen failure rate for therapy trial is higher, but the PSA response rate is higher as well. probably due to the better PET selection, and the eventual overall survival is also longer for the therapy trial. Although the two trials are not directly comparable, 40% of the vision trial patients already had cabazitaxel, and none of the patients in therapy trial had cabazitaxel, and the dosing is slightly different between the two as well. But nonetheless, I think there's a suggestion here that FDG PET may be able to help identify patients who will benefit most from treatment. So what is the role of FDG PET here? So the disease can be heterogeneous at the advanced stages of prostate cancer, and FDG PET really helps us to identify discordant FDG disease. And what is this? These are areas with low or no PSMA uptake but with high FDG uptake, for example, the liver disease over here. As these sites are often poorly targeted by radioligand therapy, and are often sites that are more aggressive and will progress despite treatment. So some may argue that these sites can be identified through correlative CT scan on a PET CT scan, but this is really only possible if the lesions are large enough, large soft tissue lesion, which can be seen on a CT scan. So for example, for these patients over here with only small bone metastases, you may think that you can target all these lesions with a radioligand therapy, but this patient also had quite a significant discordant FDG disease that is seen on FDG PET scan. So these patients may not be so suitable for treatment. So when we look at the initial phase 2 prospective trial of Peter McCallum, the 16 patients who are ineligible for treatment, either due to low PSMA uptake or discordant FDG disease, compared to the 50 patients who are recruited into trial, the median overall survival is quite different, although 9 of the patients who are ineligible for treatment subsequently receive systemic treatment. So proposing that the dual PET imaging can help identify patients with short survival as well as poor prognosis. So subsequently, therapy trial did publish their analysis on baseline PSMA and FDG PET of the patients who are recruited, and so these patients do not have discordant FDG disease, they may have concordant FDG disease. So they found that patients with a lower FDG PET metabolic tumor volume have better outcome. So the PSA response is higher, the radiographic progression-free survival is longer, and the overall survival is longer as well. So even for patients who are undergoing a radioligand therapy, so FDG PET can serve as a prognostic biomarker. So we've been talking about excluding patients with discordant FDG disease, patients with FDG positive, PSMA negative lesions. How do we actually know that PSMA radioligand therapy actually improves survival in this cohort of patients? So this retrospective study from Germany actually treated patients with discordant FDG disease, and indeed they found that these patients actually indeed did poorly compared to those without discordant disease. There are, however, studies out there that do not show that FDG PET do predict treatment response, and some say yes, FDG and PSMA PET do provide complementary information, but yet there is less than 5% of mismatch findings when they look at the PSMA and FDG PET findings versus the PSMA findings alone. I think the key here really is the percentage of mismatch. The percentage of discordance. You know, what percentage of discordance would you call as discordance? 3%, 5%, that you will exclude patients from treatment. And as Heather previously shared, currently there's no consensus yet on the use of radioligand therapy only in patients with concordant findings on both FDG and PSMA PET. I think at the end of the day, cost is a major consideration for having both scans in many countries, I mean Singapore included, in addition to the high cost of PSMA PET as well as radioligand therapy already borne by the patients. So these are my take-home messages. Again, very different mechanisms here. FDG PET is looking at glucose utilization, PSMA PET on PSMA expression. So early prostate cancer tends to have a lower FDG uptake, so PSMA PET is better than FDG PET in this clinical setting. But FDG PET do have a role in aggressive non-PSMA avid disease, in prognostication of disease, as well as theranostic selection. So for better selection of patients for treatment, as well as for those patients who are treated, it can serve as a prognostic biomarker. For theranostic selection, I think there's still some areas to be fine-tuned to completely justify the cost of an additional scan. So thank you very much. That's all from myself.